Thank you very much, Tim. As the slide implies, I spend a lot of my time irradiating eyes. I work as an ocular oncologist. So what I want to talk about today is, in general, the effects of radiation on the retina. There we go. So when we talk about ionizing radiation in general, our perception, of course, has changed over the years. If we think back to 1920, is it just? Yeah, it's the left. I always have this difficulty. Yeah? Pressing on the left? Yeah?
Try right-clicking, Mike.
Okay. Right. Can I go back?
Left click.
Okay, we can work it this way. Right, so, about in the 1920s, radiation was actually thought to be a good thing. In fact, you could buy off-the-shelf bottles of radium water, which were actually supposed to enhance your health. Of course, by about 1945, just 25 years later, with the advent of the atomic era, we began to realize the significant effects of radiation. So, what about our perception of radiation retinopathy? Well, the common perceptions are that radiation retinopathy is inevitable, that it's permanent, that it's always associated with visual loss, and it's untreatable. And I want to revisit these perceptions a little later. But first, let's look at the basic clinical features. Now, you've heard Tim talk about the microvascular abnormalities, but in ocular oncology, we often see significantly more changes than just simple microvascular abnormalities. And the changes that we see, microaneurysms, telangiectasia, intraretinal hemorrhages, capillary non-perfusion, exudates, and cotton wool spots. And of course, many of these are the features that you'd see in straightforward diabetic retinopathy, and the changes are indeed similar. Now, is there a minimum dose? And this is a question I'm frequently asked. Is there a minimum dose after which you're going to start seeing radiation changes? Well, if you look in animal studies, you'll see that changes occur, and these are often histological and ultrastructural studies, they occur at a dose of about 15 to 20 gray, and the signs that you'll see is endothelial cell loss and areas of capillary closure. If you look in the wider literature, you'll see that there are reported changes in the retina after doses as low as 11 to 15 gray. But you have to put these reports into context. These are, in general, sporadic case reports that have been reported because they are different from the norm. And so these are the exceptions rather than the rule. And they're also often skewed because of other effects which can affect radiation. For example, chemotherapy, and it's well recognized that patients who are on chemotherapy may be more sensitive to radiation than those who are not. So, what's important in radiation retinopathy? Well, one thing that's important is the total radiation dose, and that makes sense that the more radiation you give, the more likely you are to have retinopathy. If you fractionate the radiation, the fraction size is also important. So if you give a large dose in one fraction, compared with smaller doses in many fractions, in general, the effects of the fractionation will be beneficial. So in general, these are the sort of take-home messages. Radiation dose, the minimum dose that you use to start to see significant changes is if you give a dose of about 30 to 35 gray of cephalic radiation, and that this increases with cumulative dose. So when you get to 60 gray, about 50% have retinal changes, and when you get to 78 or 80 gray, about 75 to 85% of the retinas will show changes. So I want to put this in context. So the Oraya therapy, you're using 60 gray. As an ocular oncologist, these are the sort of doses I use. Well, I use three principal types of radiation. The first is stereotactic radiation. I have to say it's a very different stereotactic machine to the one we're talking about here. The gamma radiation dose, the retinal dose is 35 to 70 gray. That's the immediate surrounding retina. If we use proton beam irradiation, and we do use proton beam using the Douglas cyclotron in Clatterbridge, The radiation dose there is about 58 gray gamma equivalent. If we use ruthenium plaque, and here we're using a beta emitter, then you'll see our retinal dose rises to between 350 to 800 gray. So, when is the onset of radiation changes in patients who are subject to radiation for tumors? Well, we see with radioactive plaque about 4 to 32 months is the sort of range, and a medium about 14 to 16 months. With external beam, it's something similar, 7 to 36 months, with a slightly later median. This is old data, but it's data that still holds true. The take-home message here, of course, is that after 3 years, the likelihood of developing significant radiation retinopathy declines dramatically. So, let's have a look at these perceptions. Radiation retinopathy is inevitable. It's incorrect. It usually occurs at a clinically significant level over doses of 30 gray. And here indeed is a patient that I have irradiated using a plaque, something in the region of about 600 gray to the surrounding retina, and this patient has 6/5 vision 4 years after treatment. Radiation retinopathy is permanent. Well, this again is incorrect, and as you've heard from Tim, in the study, a lot of the microvascular changes subsided with time. And this is something, as an ocular oncologist, that I frequently see, is that patients will develop radiation retinopathy, and then with time, spontaneously, these changes will resolve. Radiation retinopathy is always associated with visual loss. Again, this is incorrect. As you can see here, this is a patient who is, again, being treated by plaque therapy, and you can see here complete destruction of the retina and choroid. This is the residual tumor mass. This was probably in the region of 700 gray to the surrounding retina. Optic disc here, normal vision in this eye. Radiation retinopathy is untreatable. Well, if I'd been giving this lecture 6 or 7 years ago, I would have said that radiation retinopathy is untreatable in general. We tried things like pan-laser, argon laser photocoagulation, but the results of it were not particularly good. But here's a patient treated with proton beam for a juxtapapillary melanoma, so they've had in the region of 60 gray to the optic disc, florid radiation changes, papillopathy, retinal changes, 3 doses of Avastin, and the radiation retinopathy has completely subsided. Okay, so there it is. So in conclusion, significant radiation retinopathy is actually rare below a total dose of 30 gray. Most cases of radiation retinopathy occur before 36 months. Radiation changes may be transient, and the vision may be totally unaffected by these changes. If radiation retinopathy does occur, then it's often amenable to anti-VEGF therapy. Thank you very much.
Any questions? I've got one in that case. I mean, when you look at the microvascular abnormalities that we're seeing with this device, what are your thoughts on that compared to the kind of...
That's a good question. I actually have looked at a lot of the cases, and I have to say that in general I thought the microvascular changes were insignificant. And some I actually struggled to see them. So I really felt that you were stretching the envelope to call them significant microvascular changes in the majority of cases.
Yeah, I mean, this is going to sound slightly promotional, but actually I've looked at a few of them myself, and oftentimes 3 of us would look at them and 2 would call it yes, 1 would call it no, or the other way around, and sometimes they are extremely subtle.
Yeah, I think people have to exercise caution and err on the side of caution, and that if they suspect a change, then they will record it as such. But looking at it impartially, when I viewed these, I found it difficult to see the majority of changes that I've been seeing.
No, interesting.